Assalamu alaikum. We'll discuss today another topic in the field of uveitis, sympathetic ophthalmia. In the past, it was thought that sympathetic ophthalmia is a blinding disease. This is not true anymore. It's a disease like any uveitic entities, like as you see, it has a lot of similarities with volcanic heart disease. If you start the treatment early and aggressive enough, you can control the inflammation and you save the eye. So what is, it's like volcanic heart disease. It's bilateral granulomatous baniovitis. The histopathology, as you will see, is very similar to that of volcanic heart disease. So it's bilateral granulomatous baniovitis. And this kind of baniovitis occurs as a complication of penetrating injury that involves the uvea of one eye. But the message, the first message that I want to give you today, that the penetrating injury could be either accidental trauma, but also surgery. Patients can have sympathetic ophthalmia after intraocular surgery, particularly vitreoretinal surgery. I'll show you some examples. It is not common, but it happens. That's why we should be aware of this to treat the patients urgently and adequately. The injured eye, the eye involved by trauma, is called the exciting eye, and the fellow eye is the sympathizing eye. If you look at the incidence, it is reported after 0.1% to 0.3% of patients after accidental trauma. So this is after open globe injury. But after intraocular surgery, it is reported in 0.015%. The risk is exceptionally high in patients after neodymium YAG cyclotherapy. We don't know why, but the risk is extremely high, and I have one case to show you. So it is reported in 5.8% and 0.67% after non-contact and contact neodymium YAG cyclotherapy, respectively. Is it a procedure that is still done for glaucoma?
No, cyclophotocoagulation now.
Yeah, okay. I summarize the literature to show you the importance of ocular surgery. In the different series, the first series, published by the late Donald Gass, 45% of the cases of sympathetic ophthalmia in his series were after intraocular surgery, particularly vitreoretinal surgery. In the second series, 17% of the case of sympathetic ophthalmia followed intraocular surgery. Third, 28%, 56%, and 70% in a series that came from Singapore by Dr. Chi. So, and the last one, 38%. So, considerable number of sympathetic ophthalmia cases followed intraocular surgery. So to summarize, ocular surgery, particularly retinal surgery, is now a greater risk than accidental trauma. That's why we have to be careful. I don't like to say this, but I lost one patient, a patient who had retinal reattachment surgery for chronic RD in his left eye. I was in holiday in summer. The patient came to the emergency room because of inflammation in the fellow eye. But the resident who was around could not make the diagnosis. And so when I saw the patients after the holiday, in fact, the patient was mentally retarded. He had chronic sympathetic ophthalmia. She missed it. So that's the reason why this is an important lecture, that we should not miss a case of sympathetic ophthalmia in the emergency room. An eye that has inflammation after accidental trauma or surgery in the fellow eye should be suspected to have sympathetic ophthalmia. Is this message clear? So by Dr. Ken Martin and the associates, they reviewed cases prospectively of sympathetic ophthalmia after retinal surgery and reported one case in about 1,150 retinal detachment procedures. So the risk is present among after vitrectomy or vitreoretinal surgery. So if you look at the rule of vitrectomy, this is from Donald Gass' paper. He reported the rate after vitrectomy to be 0.06%, and the rate is more, 0.01%, when vitrectomy was the only operative procedure and penetrating wound. It was less. So the risk after vitrectomy is high when you do vitrectomy for trauma cases. It is less if you do just vitrectomy. The paper of Ken Martin, he showed that the risk of 1 in about 800 vitrectomies. So it's considerable risk. So vitreoretinal surgery is an important risk factor. It may be appropriate to counsel patients about the risk of sympathetic ophthalmia before performing vitrectomy. Any bilateral uveitis following vitreoretinal surgery should alert the surgeon to the possibility of sympathetic ophthalmia. Now, there was a big discussion in the literature about evisceration. There are sympathetic ophthalmia cases reported after evisceration. And we know that after inoculation, none of the patient will develop sympathetic ophthalmia. So it is thought that the uveal tissue may be left behind after evisceration and act as the source of the immune response to induce sympathetic ophthalmia. And that was there was a lot of discussions, but at the end, it was concluded that you can do evisceration if needed, but you have to follow the patient carefully. So there should be a high degree of clinical suspicion is required after evisceration. So evisceration has a risk, but this does not mean that we should not do evisceration if needed, but you should have high degree of risk. The interval between trauma and the onset of inflammation, the range is very large, from 5 days to 66 years. However, 70 to 80% occurs within the first 3 months after trauma, and 90% within 1 year of injury. The peak, as we will see, occurs at 4 to 6 weeks following injury. I'm going to show you different cases of sympathetic ophthalmia from our practice, just to make you familiar with the diagnosis and treatment. The first case is a patient who developed sympathetic ophthalmia after vitrectomy to repair rhegmatogenous retinal detachment. All these patients, I prefer to put an encircling band. We do vitrectomy, we flatten the retina under perfluorocarbon liquids, and then we apply laser foot coagulation to the break. So this was a 50-year-old man, underwent successful retinal reattachment surgery with Barcelona vitrectomy and gas tamponade. I saw the patient post-operatively, first post-operative visit, he was fine. But the patient came to the emergency room, and then the resident called me and he said, I am seeing a patient for whom you did vitreoretinal surgery to flatten his retina, but now the patient came with recurrent detachment in the operated eye and a new detachment in the fellow eye. Do you understand this? The resident thought that the eye that I operated had recurrent detachment, and the fellow eye had also retinal fluid. So this is, he developed new detachment. This looks unlogic, huh? So I came and saw the patient, and indeed it was sympathetic ophthalmia. And in the acute phases of sympathetic ophthalmia, the patient, of course, will have like VKH, oxidative detachment. So he did not have the knowledge to make a diagnosis of sympathetic ophthalmia. He thought that the patient had bilateral rheumatoid detachment, recurrent in one eye and new in the other eye. So the patient developed sympathetic ophthalmia 5 weeks after surgery. The patient was admitted, treated urgently and aggressively with intravenous pulse steroid methylprednisolone, 3 days followed by oral prednisone plus cyclosporine. This resulted in control of inflammation and good visual prognosis. So this is the patient, this is the sympathizing eye at presentation. You can see the disc is hyperemic and you can appreciate in the sympathizing eye oxidative detachment. You have to know that in the acute phase of the disease, the picture is exactly the same as Vogt-Negre disease, exactly the same. Disc hyperemia, oxidative retinal detachment, fluorescein geography is the same, ICG is the same. So that was the sympathizing eye, the one that the eye that the resident thought it could be new retinal detachment. And then this is the exciting eye, the patient, the eye that was operated. You see oxidative RD and disc hyperemia, same like VKH. Looking at fluorescein, exactly the same like VKH. This is the right eye. You see hypofluorescent dots representing granulomas that are seen in the early phases of fluorescein angiography, pinpoint leaks, and pooling of dye under the retina, exactly the same like VKH. And on ICG, you remember when I talked about VKH in the acute phase, the choroid on ICG show multiple hypofluorescent spots corresponding to choroidal granulomas. So the ICG is the same. And the sympathizing eye, oxidative RD, multifocal oxidative RD, and undulations at the level of the RPE, which exactly the same like VKH, and the exciting eye. So as I said, the patient was admitted, started on IV methylprednisolone for 3 days, and followed by oral prednisone 1 milligram per kg body weight, and cyclosporin 5 milligram per kg body weight, and we ended with this. The eye, the exciting eye, the eye that I operated for retinal detachment, ended with 20/100 vision, flat retina, and the sympathizing eye, the eye that developed sympathetic ophthalmia, 20/30 vision. So this is an example of sympathetic ophthalmia after a straightforward procedure, successful retinal. That's why I published this case years ago as sympathetic ophthalmia after successful retinal reattachment surgery. Second case. This is a sympathetic ophthalmia that developed after retinal. Patient had retinal reattachment surgery done elsewhere, not in our hospital, with silicone oil tamponade. So this is 30-year-old man underwent retinal reattachment surgery with silicone oil tamponade in his left eye 3 months prior to presentation. Visual acuity was at presentation counting finger. Again, the patient treated with IV methylprednisolone followed by oral steroids, plus mycophenolate mofetil as an immunomodulatory agent that resulted in corneal inflammation. Now, looking here, this is an exciting eye. What do you see here? Excellent, pseudohypopium. So the patient had emulsified silicone oil in the exciting eye, and this is the sympathizing eye, counting finger 2 feet. Now, view is very hazy in the exciting eye. Sympathizing eye, hyperemia of the optic nerve, head, and oxidative RD. Ultrasound, oxidative RD and second choroid, and then fluorescein angiography, similar to the previous case. Bullous oxidative RD. So the patient was treated, and 2 months after presentation, 20/30 vision. Of course, the other eye, later on, I removed silicone oil from this eye, and I augmented retinopexy. So again, with early intervention and the proper early diagnosis, prompt diagnosis, prompt intervention of zoom subsurvey can save the eye and ends with good outcome. Next patient. This is a patient that had developed sympathetic ophthalmia after complicated cataract surgery and intraocular implantation. He was a 50-year-old man. Developed, as you see, most of them weeks. Sympathetic ophthalmia 8 weeks after cataract surgery. He had cataract surgery done elsewhere. So the patient had a very bad cataract surgery. The lens, the IOL was subluxated. The inferior haptic was rubbing against the ciliary body. The superior haptic was hanging in the pupil. Again, the patient treated was with steroids, cyclosporin A, and then I did barzellana vitrectomy, and I removed the dislocated lens because I thought that rubbing, the haptic rubbing against ciliary body is an inciting factor. So this is the eye that was operated, very bad. I don't think it's very clear, but the haptic was here, hanging here in the pupillary area, and this is the other eye, sympathizing eye. Inflamed optic nerve head and exudative RD, and then the typical fluorescein angiography, and then after they did vitrectomy, removed the dislocated lens, we ended with 28 divisions, the exciting eye and sympathizing eye 2030. After penetrating trauma, so the first part of these cases were after surgery. That was a very sad case. 15-year-old girl, I just saw her yesterday, follow-up in the clinic. 15-year-old girl involved in a road traffic accident, penetrating trauma with multiple large glass intraocular film body, many large pieces of glass in the eye. This eye ended with PVR, proliferative vitreoretinopathy. Developed sympathetic ophthalmia 6 months after trauma. She was very smart. Once she had the early symptoms, she came with her mother to the emergency room. Visual acuity at presentation was 20/100 in the sympathizing eye. Treated the same, mycophenolate mofetil, intravenous and oral steroids. When I saw her yesterday, we stopped all the medication for her. We ended with vision 20/25. This is the exciting eye. You can see these pieces of glass. It's very aggressive. And the retina ended with BVR, unfortunately. And now, when she presented with early sympathetic ophthalmia in the sympathizing eye, optic disc, hyperemia, and exudative retinal detachment, and then fluorescein, can you appreciate the pinpoint leaks?
Yes.
That was very early. And then ICG, many granulomas. Exudative retinal detachment, and then 20/20 vision. Alhamdulillah, 20/20 vision. With normal fundus, no sunsingular fundus. That's because we started early. So the early intervention with immunosuppressive therapy is very important to control the inflammation, prevent complication, preventing the development of sunsingular fundus and evolution into chronic recurrent disease. Another patient after penetrating a trauma, 20-year-old man, developed sympathetic ophthalmia 12 weeks after sustaining penetrating trauma with a nail. I'll show you the picture. He treated similarly with steroids and cyclosporin, but as you can see the X-ray, the eye, there was a nail at presentation, and the nail was removed, but he ended with no light perception and cataract. So he developed sympathetic ophthalmia, vision reduced to 20/100, sympathizing eye, same, disc hyperemia, and exudative retinal detachment, and fluorescein angiography, typical findings. The patient was treated, and we could save also this eye. The last case after cyclophotocoagulation. So cyclophotocoagulation, as I said, is a risk factor. 40-year-old lady, the left eye was blind since childhood with no known clear cause, developed sympathetic ophthalmia 9 weeks after cyclophotocoagulation. That was done prior to referral in another institute. This is a blind eye, and this is the sympathizing eye. This hyperemia, exudative detachment, exactly same like VKH and exudative retinal detachment. So what is the differential diagnosis? The main is VKH. The only difference between sympathetic ophthalmia and VKH is ocular trauma or surgery. If the patient has ocular trauma or surgery, so this will be sympathetic ophthalmia. Clinical findings are the same. Treatment is the same. The only difference is that VKH patient has no ocular trauma or surgery. Pathogenesis. The genetic predisposition is very similar to that of VKH disease. There is increased frequency of HLA-A11 antigen in patients with sympathetic ophthalmia. It is associated like VKH with HLA-DRB104 and DQ-A103 and DQ-B104 among Japanese, British, and Irish patients. The pathology is similar in both eyes, exciting and sympathizing. It is a diffuse, non-necrotizing granulomatous choroidal inflammation with Dahlen-Fox nodules, same like VKH. If you look at the literature, they always describe a sparing of the choroid capillaris or retina. This is not very characteristic. So the choroid in this patient, same like VKH, is markedly thickened with diffuse infiltration composed of numerous lymphocytes, monocyte macrophages, epithelioid cells, and some of these epithelioid cells will produce granulomas. So that's why when you do ICG, you see hypofluorescent spots because of the granulomas. This is, we published some years ago a paper on the immunopathology of sympathetic ophthalmia. These eyes were stored at the University of Ghent, Belgium. So I did this study in collaboration with my colleague, Professor Philip Castellin, and because they had good number of paraffin-embedded eyes that were inoculated after sympathetic ophthalmia. So he had a discussion with me. We were in an international meeting, and they said, we have good number. Are you interested to examine these eyes to examine the immunopathology? So I did the study at the University of Leuven, where I do my research. So this was from this study. This paper was published in journal Eye, and this is an important paper. I'll tell you why. So this is hematoxin and eosine staining of the choroid. You see how the choroid is full of mononuclear inflammatory infiltrate. And then you can see granulomas. These granulomas are formed of epithelioid cells, which are belonging to the monocyte macrophage lineage. So this, you can see these granulomas. And then Dahlen-Fox nodules is a feature, Dahlen-Fox nodule is a histopathologic feature. It's not a clinical sign. Frequently, I see residents, when they see this hypopigmented scars in the periphery, they call it the Dahlen-Fox nodules. This is wrong. Dahlen-Fox nodule is a histopathologic feature. Is that clear? Dahlen-Fox nodules are seen in about 1/3 of inoculated eyes. These are nodules or granulomas composed of lymphocytes and monocyte macrophages located between the retinal pigment epithelium and the pores membrane. And characteristically, in sympathetic ophthalmia, the monocyte macrophages are containing pigment. This is from the study. This is staining for T lymphocytes. So the red cells are the ones that are T cells because they are stained for T cells, for the antibody to characterize T lymphocytes. But here, this is staining for B cells. All the red cells are B cells, B lymphocytes. So what, if you compare T cell staining with B lymphocyte staining, which one is more numerous? That's important because we showed that B lymphocytes are heavily involved in sympathetic ophthalmia, and this is very important. when it comes to treatment. You remember, I think I gave the lecture on VKH when I told you in VKH we have strong evidence that B cells are involved in the immunopathogenesis. مش كده؟
Yes.
And this is based on our analysis of aqueous humor samples in which we demonstrated that a B cell chemoattractant and activating factor called CXCL13 was only present at high levels in VKH eyes compared to Behçet's HLB27 and other Vedic entities. And this was the second proof that B cells, because here we have sympathetic ophthalmia histopathology is very similar to that of VKH. Which means that why it is important for treatment that in refractory cases, in resistant cases, if you want to treat with a biologic, and the biologic of choice should be, huh? Which biologic should target B cells? Rituximab, which is a B cell depleting therapy. That's why we were the first to publish on a series of patients 2 years ago on the use of rituximab to control resistant inflammation in patients with VKH, concurrent VKH. And this is also one factor that gave us because nowadays it is believed that B lymphocytes are playing a major role in autoimmune diseases, such as multiple sclerosis, rheumatoid arthritis, systemic lupus erythematosus, and other autoimmune diseases. So, and this is staining for monocyte macrophages, CD68 marker, and you can see the large epithelioid cells that are belonging to the monocyte macrophage lineage, which are stained positive for CD68. And this is the lymphocyte nodules. And you can see monocyte macrophages in these nodules. This is a staining for HLA-DR. HLA-DR is a marker of activated immune cells. So you can see many positive cells indicating active immune cells. So that was the histopathology that we published years ago. As I said, the inflammatory infiltrate with HLA-DR positive. These are active inflammatory cells are able to initiate immune response. Now, how about the management? Prevention. Prevention, if you encounter a patient with open globe injury, the wound should be carefully closed with microsurgical techniques as soon as possible. This is a preventive measure. Prompt microsurgical closure of open globe injury. Very important. Okay. Another preventive measure. It is thought that if the traumatized eye has no potential vision, nil vision, you have to make sure that no potential vision, it is better to inoculate this eye within 2 weeks of injury. It is better to inoculate this eye within 2 weeks after injury. But you cannot do this 1 day, 2 days, 3 days after trauma. You have first to make sure that the eye has no potential vision. Is that clear? Never inoculate an eye in which there is doubt that the patient can have even light perception. Huh? Now, some were suggesting that if the patient develops sympathetic ophthalmia, the fellow eye, so sympathetic ophthalmia developed, if you inoculate the traumatized eye, this can help in controlling the inflammation. This is wrong. So inoculation of the traumatized eye after the development of sympathetic ophthalmia is not correct. And I put the reference here. That was the opinion that says that inoculation within 2 weeks of onset of sympathetic ophthalmia is associated with a relatively benign clinical course and improved visual outcome. This is not true. So it is not justified to remove a functionally useful injured eye in an established case of symptomatic ophthalmia for the purpose of decreasing inflammation. Should not do this. But that was a practice in the past. So the treatment of established cases, early diagnosis, like VKH, did I tell you? VKH cases, when they present early presentation was quite, you still remember the lecture, was quite anterior segment at presentation, this gave us, these eyes had the best outcome. But if the patient come late, what called delayed presentation, with anterior segment inflammation, the chances that this patient will progress into chronic recurrent evolution is about 30%, and the chance to develop sunset fundus is about 50 or 60%. So everything here depends on the urgency of treatment and presentation. So you need early diagnosis, and you need prompt and effective treatment with systemic immunosuppressive agents. And this has been shown to improve the outcome. All the patients, they need corticosteroids. Why corticosteroids? Because corticosteroids act very fast. You cannot use corticosteroids at with large doses for a long time because complications are many. And I always tell that corticosteroids are the most toxic drugs to be used to treat patients with uveitis. We always give steroids at large dose at presentation because they act very fast. In addition to an immunomodulatory agent, I'm repeating this many times, such as mycophenolate mofetil. And then mycophenolate mofetil needs like 8 weeks to be effective. At that time, we taper the steroid to safe level, what we call the steroid sparing effect, and we consider safe level 10 milligram or less. That's why, if you come to our clinic and the residents who rotated with me, you will never see patients with cushion-late face. You will never see in our clinic patients with cushion-late face. And our strategy to control the inflammation, like in sympathetic ophthalmia or VKH, is we give 3 doses. Nowadays, I give for VKH 5 doses of IV methylprednisolone in adults, 1 gram for 5 doses, 5 consecutive days, followed by oral prednisone 1 milligram per kg per day. And we are very careful in the tapering, especially during the first 2 months. We need at least 2 months until mycophenolate mofetil is effective. This is not only for mycophenolate mofetil, but also for all other antimetabolites. So we showed that with this regime, we have successful outcome to control the inflammation and good visual prognosis, as I showed you. And again, the success here is related to prompt and adequate systemic immunosuppression using combination of systemic corticosteroids and immunomodulatory agents. So in conclusion, sympathetic ophthalmia is a rare disease. انت جاي طالع على conclusion.
يلا الله يعطيك العافية.
Sympathetic ophthalmia is a rare disease. It's a major sight-threatening disorder. I told you the story. That the young patient, mentally retarded, I operated his left eye for chronic retinal detachment. The retina was attached, he was stable. And then came to the emergency room. He was complaining that he cannot see with a good eye. And the resident missed the case. It's very painful. We don't want this to happen again. Each one of you should be aware of sympathetic ophthalmia, particularly after vitreoretinal surgery. So it is a major sight-threatening disorder. Therefore, high index of clinical suspicion must be maintained whenever inflammation occurs in the fellow eye, which we call sympathizing eye, of an eye that suffered either penetrating trauma or intraocular surgery. Infection should be carefully ruled out. Diagnosis is made clinically. You don't need histological proof. Some people who wanted to inoculate the exciting acid because to confirm histologically. This is not correct. Like VKH, the diagnosis is made clinically. Clinical findings, fluorescein OCT, fluorescein angiography, and the ICG, and even with OCT, you can check the thickness of the choroid. An injured eye or the exciting eye, which have potential vision, should not be inoculated in an attempt to prevent or reduce the inflammation in sympathetic ophthalmia. The prognosis in the past was considered to be poor. This is before the use of systemic immunosuppression. Today, it should no longer be regarded as a blinding disease. Prompt and adequate systemic immunosuppressive therapy with systemic steroids and steroid-sparing agents has improved the prognosis. Thank you very much for your attention.